everybody, welcome back to another episode of the Core Consults RX podcast. Cole is back with me today, finally done with being sick, hopefully.
Mostly.
Man,
it was rough.
Yeah, you were out for like a couple weeks.
Yeah, it was, I don't think I've been that sick since I was in like middle school.
That's not good.
And it wasn't like the normal players that everybody's getting. It was some mystery illness that we couldn't identify.
No.
Just like, but like, you know, like flu symptoms,
Yeah.
but like rough.
Did you ever get tested for flu?
No, but other people around me who had it did, and it was negative. But I don't know that I beat it so much as it beat me, and I crawled back slowly.
I know. Hey, that's at least you came back. That's
And
the big thing.
If not dying is beating, then yeah, I guess I did.
Yeah, well, there you go. That's good, man. Well, glad to have you back. Glad everybody's feeling better.
Yes.
Our long lost buddy AJ filled in last week for you to do a patient case.
Appreciate it.
We're happy to have him in the hot seat for once. But today we are going to be doing another accredited episode covering the American Diabetes Association 2023 guidelines. I'm going to go through some of the updates, and thanks to our friends at freece.com for partnering with us once again and getting this ACPE accredited through their contacts and their website. So if you are an unlimited member on freece.com, after you listen to this episode, you can follow the link in the show notes or just go to their homepage, click learn, and you'll see podcasts, and you can see all the episodes that we have available on their website that are accredited, and take the post-activity test for this particular episode. It'll ask for a password, which is going to be ADA 2023. The ADA is all caps, and that'll give you access to the test. And then once you complete that, then you will be able to get 1 hour continuing education credit for pharmacists and nurses. If you are not a free CE member, make sure that you check out all the content on their website. They have all kinds of monographs that you can get continuing ed from just reading through the monograph. You can watch live lectures. You can watch our podcast or listen to our podcast. They have live events all the time, all kinds of good stuff. So make sure you check them out. We also have a discount code in the show notes as well that you can use that will give you a discount off of a unlimited membership. And thanks to them for partnering with us. But where do you want to begin with this? Because we've already done a couple episodes with diabetes injectables. We did oral medications. We talked about SGLT2s and GLP-1s.
Yep.
So we won't bore you guys with more of that stuff because we've already kind of gone through a lot of it.
Right. So this is more of an update of the 2023.
Of the updates.
Really about the updates is what we're going to focus on. So each year ADA comes out with a new one, which not all guidelines do come out with a new guideline each year, but this is their 2023 update, which was actually released in December of 2022. Not a whole lot of crazy changes, but definitely added some things that we've been talking about throughout the year, and then put some emphasis possibly on some things that they haven't emphasized as much before. So I figure we can talk about the treatment algorithm because that's always a big one that ends up on the PowerPoint slides of many teachers and professors in pharmacy schools and med schools and whatnot. So the main change I think with this algorithm is that usually it's just like metformin right at the top and then everything else below. This doesn't necessarily do that. It kind of splits it in between reducing risk for cardiorenal issues and then achieving and maintaining glycemic control and weight loss, right?
Yeah, and I like, because last year was the first year that blew everybody's mind that they were going to take away the metformin recommendation, and I think this goes even one step further toward like you can clearly see that they're very much in favor of looking for patient specific ways of treating and managing their diabetes. Like you can say. We've kind of looked at cardiovascular events. We've looked at ASCVD. We've looked at heart failure and CKD. But now, like right from the start, they kind of have like it split to where one side you're dealing with those types of comorbidities, and then the other side you're kind of looking at weight management, all those things like Cole was saying. And I think that it goes that much further of kind of showing like again the individualized treatment process is very. There's not like one size going to fit all with diabetes.
I don't think you'd even describe this as an algorithm. It's more of a continuum. Each of them start at the same time. It's just very comorbidity based, and depending on what they have, that's what you're going to focus on,
Right.
and then follow whatever it recommends based on that.
So those of you who are watching the video version, I just switched over so you can kind of see the algorithm here if you haven't taken a look at it yet. But it splits right to the very top. If your goal is achievement of maintenance and maintenance of glycemic or weight management or cardiovascular risk reduction, or any other renal risk reduction, you'll go to the left or the right. But you'll see the treatment options and the combinations are very similar to what we've seen in the past anyway. So just, kind of FYI for looking at that. Plus they added tirzepatide now, obviously.
Yeah, tirzepatide's there. And I think that, there's always an emphasis on weight loss, of course, but generally, I guess, I can't remember exactly what the last one looked like. It's up there kind of above metformin with lifestyle stuff.
Well, because they had like hypoglycemia management and things like that. Kind of like I remember it was kind of like wrote out like to where in different columns that you would go with. But this one actually has like them almost like ranked. So like for weight loss, for example, it'll say it has efficacy. And so for very high efficacy, they have semaglutide and tirzepatide. And then for higher, efficacy, or for high efficacy, so just the one rank under them, they have liraglutide, and then intermediate, they have just GLP-1s not listed above, SGLT2 inhibitors,
right,
neutral effect metformin, DPP-4. So like they list them out kind of like in a hierarchy, which I think is very convenient.
To me, the weight loss jumped out, which I know it's always there, but maybe it jumped out because we did have the GLP-1 weight loss effects before. But now we have tirzepatide, which is much more significant, and we see all the benefits that weight loss can bring. And so we have more than just a recommendation of lifestyle management. We have that recommendation plus potential pharmacotherapy plus potential surgery to recommend too. So they have a pretty extensive section on their weight loss recommendations.
Yeah. So, we won't go through all the different pharmacotherapy options, just since like I said, we've done those a lot. The section that I think both of us, we were talking about, but kind of before we started recording, the section that's kind of interesting that they spent a lot of time talking about is the section 7, the diabetes technology, where they really kind of went into the continuous glucose monitoring in patients that are, everything from on basal insulin. They had some rewording there. They had patients that, basically recommending, these patients that are to use continuous glucose monitoring, and also went into, how they shouldn't have interrupted access to their, the actual monitor and the sensors and whatnot, depending on what they're using. And they even went into some stuff talking about like interactions between certain like medications and things, and how they can throw off the some of the readings that these continuous glucose monitors are coming up with or reporting.
Right.
Did you have anything specifically on that, Cole?
Yeah. So I didn't realize this, but there are things that can affect the readings and give improper readings. We're aware of this, and I remember being taught this with finger stick glucose monitors. There's things that you can do, manipulations you can do with the finger, things that you can take that would affect the reading and maybe make it not accurate. Similar with the continuous glucose monitoring devices. So for instance, and it's kind of brand specific. So if you're taking more than 4 grams a day of Tylenol with a Dexcom G6 sensor, you could get high sensor readings or higher sensor readings than the actual glucose. You could also get that with a Medtronic Guardian reader if you take any Tylenol. Also, if you're taking alcohol with the Medtronic Guardian reader, sensor readings may be higher than the actual glucose. Vitamin C with the Freestyle Libre can give higher readings.
And that's 500 milligrams a day or more.
500 milligrams a day or more. Tetracycline or mannitol can both affect the Senseonics Eversense device. Never heard of that one. And then hydroxyurea can affect Dexcom G6 and the Medtronic Guardian. So I thought that was pretty interesting.
Yeah. But yeah, those are, for those of you who haven't used the continuous glucose monitoring, so they're fantastic.
Yeah.
I know I've personally had the most experience with the Libre, and the Libre 3 I think is going to be coming available very soon, if not already. And so I think that's always been I've used the Dexcom a couple times.
Right.
I think their new one
Interestingly, they do delineate between the two, because there's continuous glucose monitors and there's flash glucose monitors.
Yes.
So the Libre 1 and 2 were both flash, where it doesn't give you a continuous reading.
You
have to hold the phone or whatever it is up to the device. It'll tell you right there, but it doesn't always read it. But the Libre 3 will be or is
reading constantly.
Continuous glucose. And then the other ones that we mentioned, like Dexcom and all that, that's continuous. I think in the past, the way I thought of a continuous glucose monitor or even a flash, like a Libre 1 and 2, was for, in type 2 diabetes, was for patients who had, a lot, maybe more trouble managing their glucose. Maybe they're on multiple insulin regimens or, things just aren't going great and it's just an additional arrow in your quiver to help them. That's not really how this guideline recommends. I mean, it kind of recommends it for pretty much anybody that could get it. I don't know that you would use it for your patient who's very well controlled and everything's great. Like, it might not be totally necessary, but they recommend it pretty strongly. And they do make a comment that Medicare is apparently evaluating covering it more often
for type 2.
For type 2,
that's good, because that was I ran into that several times where at my old job, where I would have a patient even patients who were type 1s that were able to get on the like Libre 2, for example, and they were doing great, they loved it, and then they turned 65, and then going through the durable medical equipment and having to fill out the form. I mean, they've made steps to make it a little bit easier. Like Freestyle has on their website a form that you can fill out and which pharmacies have contracted with Medicare and stuff, but it's still just much more of a hassle than it used to be. But I'm really glad that they are kind of wording it in a sense that's like everyone should have access to it, especially because for type 2 patients, before at least, a lot of the trouble I'd run into is the patient would be on basal insulin but a GLP-1 instead of prandial, and so the insurance would be like, no, they have to be on 2 or 3 more or more injections a day of insulin in order to qualify. And it's like, well, what if I have someone who's A1C of 14 and I'm just trying to do some management stuff, tweaks to their regimen and whatnot, those patients aren't going to be qualified. And so, that was kind of frustrating, but it sounds like they're wording it in this way to kind of push maybe third party payers to covering it, especially if Medicare is reevaluating it. Usually the other insurance companies will follow suit.
And they include, when you're assessing glycemic control, they kind of include readings of the glucose monitor. So generally we're looking at, for type 2 diabetes patients, we're looking at A1C goals less than 7 or less than 8, depending. And I don't know if this is more related to patients with type 1 diabetes. It doesn't really specify that I can tell. But I just wanted to mention a couple of terms that they kind of reference that they're looking at with continuous glucose monitors to assess glycemic control. But one is using time in range or a glucose management indicator. And they'll say that they're looking for non-pregnant adults to have a time in range related to the glycemic control greater than 70%, with a time below range less than 4%, and different factors like that can be evaluated with a continuous glucose monitoring device that can give you a little insight, maybe a little more real time than an A1C, that only goes back 3 months or so. So I don't know exactly how they intend to use that. Maybe I should have looked further, but I thought that was interesting.
Well, and they did one section that they did sort of, I guess, reword for section 6, going back a little bit, to speak on that same kind of subject about glycemic targets. On their recommendation 6.5b, they basically outlined that patients who are frail or patients who have a high risk of hypoglycemia, that instead of having a set, goal that they need to be following as far as A1C or things like that, to consider them being a target of greater than 50% of time in that range that we'd want to see them in, and then less than 1% below range. And so we're kind of utilizing that as opposed to just shooting for some set A1C goal, which, I mean, it kind of matches the American College of Physicians. They say if you don't have a 10-year life expectancy or greater, that, just basically treating for symptom control. Right. So I like that, because I feel like there's still this, sort of just obsession with pushing patients lower, even though we know, at least historically, that hasn't really been shown to prevent or reduce negative outcomes. Right. One thing I am interested to see, though, is with the growing popularity of GLP-1s and SGLT2 inhibitors, especially now with tirzepatide, are they going to reevaluate? Right. So if we're not using,
you can more safely push people.
So, because the risk of hypoglycemia is not there. So now I'm wondering if they're going to redo some of those Accord trials or things like that.
I have to imagine, because if you look back at those, then they're using TZDs and sulfonylureas and stuff like that to push the pedal.
And that was always
insulin.
like the reason why those either didn't show a benefit or, and like Accord's example, showed harm was because of hypoglycemia. Like all of the negative, even the death that was associated with the lower A1C was all due to hypoglycemia.
Yep.
So yeah, I think that that's going to be something that to keep an eye on. And
which whether you'll still see positive outcomes from it, you might not see like harm, but you know, we would still have to evaluate to see if it's still beneficial at that
exactly
to do.
Now, just since we're talking about insulin real briefly, because one thing that hasn't really changed as far as like the recommendations, as far as injectable medications, they still recommend a GLP-1 as first line injectable if possible, and then moving on to basal, and then prandial insulin, one meal at a time, added from there. One thing that they've mentioned this before, but I don't think we've actually talked much about in detail, and it's becoming more and more obvious to me that this is a very important thing. Is the concept of over-basalization. So if a patient is on basal insulin, you know, we want to look for too much basal insulin basically being prescribed or, you know, reducing if they're seeing us in clinic. And so I've had patients, for example, who were on 70 units of Lantus twice a day.
A lot.
And realistically, there's sort of this ceiling effect that you get with basal insulin. And in some cases, that can actually be harmful the higher you go up, because then the risk of hypoglycemia occurs, and if they don't treat that properly, you know, then you're into a whole new slew of problems. Mm-hmm. But the guidelines do mention that, you know, if the basal dose of a patient is more than basically 0.5 units per kilogram per day, so it's patient specific based on their weight, then you would want to, you know, evaluate if one, you need to bring their insulin dose down, and then see if they're a better candidate for adding on prandial insulin or GLP-1 if they're not already, and kind of utilizing those postprandial mealtime spikes that are most likely causing the problem, because just adding in more basal insulin and just going up and up and up and up in the dose is not a very effective method. Right. And I went and listened to a tirzepatide CE a while back at some restaurant downtown, and they the endocrinologist that was talking, he made a comment about that, like how he'll see patients on like really high doses of insulin. He'll cut their dose of insulin like in half, and they said their A1C will improve just because they're not having these huge swings. Right.
And there's some other clinical signs that you can see that might be a sign that they have overbasalization: high bedtime to morning or post to preprandial glucose differentials. Of course, a lot of hypoglycemia. Or just like Mike mentioned, a lot of shifting, high glycemic variability can be an indication too.
Yeah, so I just want to make sure we had at least said this in this podcast, so you can't call us on leaving some important information out.
Can't say that we didn't mention it. You may have never heard that word before.
Over-basalization.
Because I don't think we've ever said it on this podcast.
I don't think we have, which I think is something we should have done. So I'm glad we're trying to correct our wrongs. All right, so what else we got?
Yeah. So next, there were some other interesting things. So they mentioned, they make a specific mention of lactose, which I thought was interesting. And they say in people who've had a stroke or have had evidence of insulin resistance and prediabetes, consider prescribing pioglitazone. The medication can reduce the risk for stroke or heart attacks as long as it be taken without side effects. So if you look at the specific recommendation, you have to be obviously cautious of the fracture risk and the retaining water, but I thought it was interesting that they made a specific mention of pioglitazone, which I don't know. I don't feel like they do mention it much in a positive way, but they at least made that mention here.
I think the one downside of that recommendation, or potentially anyway, would be if they've had an MI, you have to also assess, make sure there's no signs of heart failure. Because then obviously if they're stage 3 or 4 from the New York Heart Failure or Heart Association, standards, then that's going to be problematic.
Yep. And they rank their recommendations like A through E. It looks like maybe even F, and they gave this an A, which I was surprised by.
Yeah, there is evidence that it can be beneficial, and I've said before too, like the couple times that I've actually used pioglitazone was patients who needed insulin sensitivity. However, they weren't a candidate for whatever reason for metformin, and then pioglitazone can be useful there. So I think it does have its place. It's just one of those things that
pretty specific.
I think one of probably the biggest, I would say, section that's kind of been updated was sections 10 and 11, where they talked about cardiovascular disease, and risk management, and as well as chronic kidney disease and risk management. So, I mean, like they start off obviously discussing everything from hypertension and LDL goals and all that, but there's been some changes there. As far as the blood pressure goals, they've actually now come out and officially said, which, I mean, they've had this in the past, but they make it very clear and list out all the evidence.
It made it sound like they didn't have it in the past, but I was reading it and I was like, I thought they did have this last year. Did they not?
I thought they did too, but I'll have to go
maybe
back.
we're just too focused on AHA.
But 130, less than 130 over 80 is their official recommendation for patients with diabetes. And they did mention Sprint, but one of the issues with the Sprint trial, and you guys have heard us talk about that, but one of the issues with Sprint is that they excluded patients with diabetes. So that was always the issue with kind of quoting that specific study, which is what usually everyone quotes when it comes to, blood pressure goals. But they do have the 130, less than 130 over 80 now is a specific goal. And if I'm going to switch screens here on my computer so you can see this little hierarchy chart where they have reduction in diabetes complications, then they have glycemic management, which is the one we always obviously think about, but then blood pressure management, lipid management, and agents with cardiovascular and renal benefit is being kind of the pillars that hold up the ceiling of reduction in diabetes complications.
Looks like my kids' building blocks.
With a foundation of lifestyle modification and diabetes education. So I really, it's very simple, but I like this algorithm a lot. Yeah. It's very useful.
They did kind of harp back to other recommendations related to potentially initiating 2 blood pressure medications if they had a confirmed office-based blood pressure over 160 over 100. And then talked about needing multiple agents and things of that nature.
They did mention in pregnant patients that have diabetes and chronic hypertension that their threshold is 140 over 90 for initiation, and that there's limited kind of data on like what the lower limit should be as far as blood pressure management. But they kind of say like a blood pressure target of 110 to 135 systolic, 185 diastolic is suggested in the interest of reducing risk for accelerated maternal hypertension. And they do say that that therapy should be lessened if the blood pressure does drop below 90 over 60, but that's only level evidence E.
They had some updates related to monitoring of albumin and creatinine ratios and things of that nature, basically doing it more often, but they still have that recommendation that is doing an ACE or ARB to the maximum tolerated dose in individuals with diabetes, and a ratio over 300 milligrams, but also 30 to 299. So basically over 30 milligrams, still using that.
The other things that they actually went into some detail about was as far as like studies and stuff talking about these blood pressure goals. They did mention Sprint, and then they went into Accord and some detail as well, because Accord, if you remember, was looking at there was 2 major arms of it that were the blood pressure arm and the A1C arm. And so they were looking at, A1C, strict A1C control versus more lenient, and then strict blood pressure versus, or less or more lenient blood pressure goals as well. And that Accord study was stopped early because of the increased risk and mortality with the lower A1C or more strict A1C goals, like we just had talked about earlier. But, the blood pressure arm didn't really show a benefit overall, but they do make a comment that the pre-specified secondary outcome of stroke was significantly reduced by 41% in the intensive treatment arm. Plus, there's also that whole idea that one, it was underpowered to show statistical significance, and it was a 2x2 factorial study. So like the patients who were in the strict A1C arm, which we know was problematic and lessened or increased the risk of adverse events, including death. Some of those patients were also in the strict and A1 or the strict blood pressure arm. And so the concern is, well, did we really see? Was it really not a benefit overall of that primary composite, or was that negative outcome that was being facilitated by the strict A1C control kind of taking away the benefit that we could have seen from the blood pressure reduction? So it's one of those things that that's there's enough data now. Plus they mentioned the STEP trial, which was 8,500 patients, 60 to 80 years old, and I think it was basically patients had the same kind of thing, looking at different targets, and the patients had a better outcome when going for the lower target.
Yeah.
And so, quite a few studies to back it up. They talk about ADVANCE, they talk about the HOT trial, meta-analyses, things like that, basically backing up that recommendation. Yeah. But
similar things what people have been talking about, but yeah, the issue is the lack of diabetes in some of those that probably kept them from doing it till now.
Yeah. So as far as like the pharmacological interventions when it comes to managing blood pressure, Cole had already started talking about this a little bit, but they have it. This is a little bit different than I would say the American Heart Association and whatnot, because they say that if the blood pressure is greater than 140/90, but less than 160/100, then they want one agent being started. And if the patient does have albuminuria or a history of CAD, then they want you to go with an ACE or ARB. Mm-hmm. If not, you can do ACE or ARB, calcium channel blocker, or diuretic. Did you notice what they had in the diuretic section, though, about the recommendation?
No.
They prefer chlorthalidone or indapamide.
Nice.
Yeah, so I thought that was kind of funny.
Which after that trial came out, that is
maybe chlorthalidone's not as big of a deal.
Yeah.
But indapamide, I'll take it.
Let's go for it.
But and like Cole said, it used to be kind of everyone who had diabetes got an ACE back in the day, and then it was more so patients who have albuminuria, so 300 or more albumin creatinine ratio. But they also, with level evidence B, say that if it's patients 30 to 299, basically, to also do an ACE or ARB.
Right.
So I thought
it's still not wrong to start an ACE even if they don't have that, or an ARB.
I think it's just one of those things that we don't have to jump to it if they don't have any issues. Right. They do say that if the initial blood pressure is greater than 160/100, to go ahead and start two agents right from the beginning. Mm-hmm. Same kind of concept as far as albuminuria or CAD. They want you to do ACE or ARB plus either a CCB or diuretic. And then you just pick two of those three if they don't have that. But yeah, so basically they just kind of go through, and at that point it kind of follows the exact same hypertension algorithm that we're all familiar with, to where they would add the third agent of that list that's not already on there. And then if you needed a fourth line agent, they do recommend spironolactone or eplerenone. Yep. It's kind of like the fourth agent to be added on.
Right.
Let's see. What else do you want to? Anything with hypertension? Anything else?
I think that's all I had for blood pressure.
Talk about lipids.
Yeah.
So that was kind of interesting.
Yeah. So in general, a lot of it's pretty similar. So they're still recommending a moderate intensity statin for individuals with diabetes, 40 to 75. No other issues. They're still recommending the standard statin, but they did kind of update some recommendations related to goals, right?
Yeah. So the primary primary prevention rather with lipid management. We've always kind of said if you have diabetes and you're in that 40 to 75 years of age range, you're getting moderate intensity statin. So that was the CARD study kind of showed that. So a TORV of 10 versus placebo in that patient population was shown to be beneficial and reduce the risk of cardiovascular events. They also say that, with a little bit less quality evidence, that patients who are 20 to 39 years of age with additional atherosclerotic cardiovascular disease risk factors, that it may be reasonable to initiate a statin therapy in addition to lifestyle therapy. So we can kind of bring those, that age range down. Now, patients who have diabetes, this is still primary prevention. So patients who have diabetes that are 40 to 75 years of age at higher cardiovascular risk, and including those with one or more atherosclerotic cardiovascular risk factors, it's basically recommended to use high intensity statin to bring that LDL down by 50% or more. And they want a target LDL of less than 70. Which, thinking the guidelines when it comes to lipid management that we usually quote are the ADA guidelines. Mm-hmm. They usually save the less than 70 goal for patients who have had an ASCVD event, history of ASCVD. So you're basically thinking secondary prevention. This is still considered primary prevention for these patients. And so in this case, it's one of those things that, we're pushing that LDL goal lower than we have previously.
Right.
Now, as far as the ASCVD risk factors, there's a couple of them that they kind of go through and mention, and I wanted to make sure I pull these up really quick. What they consider, ASCVD, and this kind of goes back to the treatment algorithm as well. If you're trying to evaluate which medication for actual diabetes to start, they say that history of MI, history of stroke, and then any revascularization procedure are kind of like the all the CVOT trials or
People generally agree
CVOTs.
on
Yeah,
those
those are all in all the different studies that the FDA have required these medications to undergo. Now, other things that they have been included in some studies and not in others would be things like transient ischemic attack, unstable angina, amputation, or basically PAD,
Which is interesting, yeah.
and stable or symptomatic and asymptomatic CAD would all be like potential classifications of ASCVD.
Yeah.
Now, what they consider to be high risk factors would be if a patient is 55 years of age or older, plus obesity, hypertension, smoking, dyslipidemia, albuminuria. Those are the patients that you would basically treat just as if they have ASCVD established already. So those same risk factors are what they're kind of using to say, okay, if they have these types of things on top of their diabetes, then go ahead and put them on a high intensity statin as well.
Yep.
So you would treat them with the pharmacotherapy regimen for diabetes, for ASCVD, like the GLP-1s, SGLT2s, and they'd also be in a high-intensity statin, which I think that's kind of a little bit, different than what a lot of, maybe some of us have been doing in the past.
Right.
So, yeah, I thought that was pretty interesting.
That is interesting. A little bit different. For secondary prevention, it's mostly the same, but also a little bit different than it has been in the past. But they would say anyone with secondary prevention, they're recommending high-intensity statin with a goal reduction with the goal reduction of at least 50%. But they're putting the goal of the actual lipids to be less than 55, which we've seen in previous
endocrinology
guidelines where they would push it to, they called it something funny.
Extreme risk,
people at extreme risk to be less than 55. But this says anyone with secondary prevention, less than 55. Primary prevention, less than 70. So they're agreeing with the benefit of the lower LDL. They say use the statin, addition of ezetimibe next, or a PCSK9 with proven benefit, and the population is recommended. They don't recommend the addition of a fibrate.
Yeah. Well, and I think a lot of the lower LDL goals are coming from the PCSK9 studies.
Yeah.
So I think that's one of those situations where, are we going to be able to get patients access to these because of the cost? I mean, they're come down a little bit, but that's still a big issue. So ezetimibe usually is going to be patient's second line option for dyslipidemia. Have you seen the preliminary stuff from that bempedoic acid, the CLEAR outcome study? I don't believe it's actually been published yet, but the initial kind of they had a press release from the company basically showing the top line evidence, whatever is statistical significance.
Good.
And as of now, it's for patients who already have ASCVD to be added onto a statin, but it was like over 20% further reduction in LDL and had positive actual impact on adverse cardiovascular events in the future. So I wouldn't be super surprised if this gets added in to that list fairly soon.
Yeah.
If that study continues to show that potential, then
right.
I think that'll be a much more cost-effective option than PCSK9 inhibitors.
Yeah, that'd be very good. Which we're spoiled at our institution because people have pretty ready access to PCSK9s if they've done what they need to do and their LDL is not where it needs to be. But a lot of other places, it is more difficult.
Less than 55. So them and the ACE guidelines recommend are agreeing with that, especially in patients that have had AS. I guess they're even being more aggressive, I think, than the ACE guidelines because they're not even saying patients who have extreme risk.
Extra risk factors on top of having ASCVD. They're just saying anyone with ASCVD.
Yeah.
So yeah, you're right. That would be a little more progressive, a little more aggressive.
Yeah. So there you go. The lipid guidelines change. I'm wondering how long it's going to be before we get another dyslipidemia guideline from American Heart Association because it was 2018 since.
Yeah, it was 2018.
So it's been 5 years, guys. Time to update your stuff.
I know. It's 2023. They're all working from home during COVID.
That's why nothing.
They're not getting together and
meeting
talking about anything.
But they also, kind of talk about some of the other. I think you started to mention something about fibrates.
I did just mention that they don't recommend fibrates.
Oh yeah, just for cholesterol lowering in general. If you look at like fenofibrate specifically, they've looked at that in addition to statins in patients with diabetes, and I think that was the cord lipid arm, and didn't see a benefit of adding fenofibrate as far as outcomes go. They do mention patients who have triglycerides, so fasting triglyceride levels above 500 or above. They want, obviously, recommending the analysis for secondary causes of hypertriglyceridemia, and then considering medical therapy in those patients. If they have moderate hypertriglyceridemia, they say that it's basically 175 to 499 that you should kind of look for other issues as well. But as far as recommendations go for treatment, they're a little bit different. So if it's 135 to 499, they do recommend with level evidence A, icosapent based on the Reduce It trial.
Yep.
And
so that's where this one pops in. Was that on the last guideline?
Yeah.
That's been older.
And we've talked about this before, but so they talk about like evaluating for issues. So like secondary factors, obviously being uncontrolled diabetes, chronic liver, kidney disease, nephrotic syndrome, things like that, hypothyroidism. Those are all things that could lead to at least moderate hypertriglyceridemia or eventually high. But the actual treatment of that moderate would be with icosapent ethyl. They say to save like fibrates for if patients above 500, if not even above 1,000, which is what a lot of like the other recommendations from other guidelines and whatnot recommend a fibric acid derivative after 1,000. So that's when the risk of pancreatitis becomes a little higher. Yep. But even that, I feel like I've seen patients that have triglycerides. I mean, I've heard of patients having triglycerides in the couple, 2,000-3,000s and still have.
Would you be more concerned if a patient's on a GLP-1 plus they've got a high triglycerides like that to get them on it a little sooner?
Probably. It depends on what they're doing. Because like if they're drinking a bunch, and they have some kind of liver disease, whatever, nephrotic syndrome, something like, then maybe not as worried. I mean, I would want to bring their triglycerides down, but I wouldn't say that I would be like stopping the GLP-1 or anything like that. Right. So yeah, I mean, I think it depends on what's going on. It's an interesting kind of debate with the GLP-1s in general and like the pancreatitis, because I've heard some endocrinologists say that if it's true idiopathic pancreatitis, then they won't use a GLP-1 in those patients. But if it's something where they can definitively say patient was an alcoholic, they were this, and that was most likely leading to that, pancreatitis in the first place, some of them will even still go ahead and use a GLP-1, which is off-label, obviously. But right. It's one of those things that I think like if we could avoid the pancreatitis thing altogether, that's great. And so, yeah, I think that just adding on an agent to get the triglycerides down so that we don't have any risk of that is ideal. But I don't think we usually, a lot of times the patients aren't going to be on the highest intensity statin that they could be or whatever. So I would say maximize those first. Right. But icosapent ethyl which is brand name Vasipa, is the one they actually recommend if they're on a statin plus, so the LDL is controlled. Because if the LDL is not controlled, then obviously we want to bump up the statin if they are not on a maximally tolerated statin dose. And then that icosapent ethyl is under the brand name Vasipa, which is specific to that particular agent. Because there has been other studies that have looked, at other formulations and whatnot. So, for example, there was one that looked at a EPA and DHA combo added to statin therapy in patients that had atherogenic dyslipidemia and high cardiovascular risk. 70% of the patients in that study had diabetes, and they didn't reduce any major adverse cardiovascular events when you added in that comparator, right. Versus placebo, rather. So, I think the big, issue that people have with the Reduce It trial is that the placebo arm was mineral oil. And so patients say that could have thrown off the results a little bit. But until we have something better to go off of, I don't really know what else, I wonder if
they could have put like olive oil in there or something.
I don't know. The study that I was talking about that didn't show a benefit with that DHA EPA combo was they used an inert comparator of corn oil.
That's an option.
So
they're kind of high in,
yeah. So I feel like that would also potentially be an issue. But so maybe icosapent ethyl would have, maybe showed even better benefit if they, I don't know, whatever. I know. But so that's kind of a weird. Maybe they just have a hard time coming up with placebos for gel capsules.
I mean, I guess the those capsules are so distinct and kind of, maybe they just wanted to make sure that the people really thought that they were taking the right thing,
Yeah, I guess. But yeah, so that's the one that they recommend adding to it. They actually do mention bempedoic acid as a potential for. They just basically say that they're waiting on other data until this if the patient, unless the patient can't tolerate other evidence-based options, then that's out there. But I think that will get a little bit more attention here very soon.
They do mention niacin, which obviously is not used as much anymore, but they mentioned that it's not been shown to provide any additional benefits, so they don't recommend niacin.
They actually say statin plus niacin combination has not been shown to provide additional cardiovascular benefit above statin alone. So it's actually been proven, and that's level evidence A. So it's literally been proven to not be beneficial. And niacin can actually make your the diabetes be a little bit harder to control as well. Mm-hmm. So I try to avoid niacin at all costs.
Are any of their antiplatelet recommendations new?
I don't think that they're new, but I don't think we've really talked too much about them because they have a pretty big segment. I mean, I think, I shouldn't say they're not new because I think some of the wording around
it seems a little bit different.
Like the antiplatelet dual antiplatelet therapy, right. I think is a little bit different.
So just to run down it a little bit, they mention aspirin therapy, your usual aspirin preventative for secondary prevention with patients with diabetes who also have ASCVD. For people with ASCVD and an aspirin allergy, they say clopidogrel can be used, and that's a reasonable option. The dual antiplatelet therapy with a low-dose aspirin plus a PTY12 inhibitor like clopidogrel would be reasonable for a year after an acute coronary syndrome, but may have benefits beyond this period. Is that the kind of wording that's a little bit different?
Yeah, and I'm looking through the summary just to see if they actually had that last year, and they're not really mentioning any of that, so that might have been there last year as well. Yeah. But I don't think we've ever talked about it on the podcast.
Right.
Aspirin therapy. So we have talked about really the primary prevention usefulness of aspirin, right. Not really being that beneficial. However, the one caveat in the one study that did show a little bit of benefit was specifically in patients who had diabetes, and so that was with the Ascend trial, I believe, or the Arrive. There was a Spree, Arrive, and Ascend. I can't remember which one's which.
All those A's.
But I think it was the Ascend had patients with diabetes, and they had, did see a benefit with aspirin for primary prevention, but they also saw the high risk of GI bleed. So those two things were basically very similar. The number needed to treat versus number needed to harm were very similar. So I think that's one of those things where obviously going to be a patient discussion. I still personally probably stay away from aspirin for primary prevention. Mm-hmm. They do still recommend with level evidence A of secondary prevention use of aspirin, 81 milligrams. They say 75 to 162, but 81 is usually what most people end up using. They talk about patients who have had, you're using it for secondary prevention, but have an allergy to aspirin, to utilize clopidogrel 75 milligrams per day can be used instead with level evidence B. And then the other thing is combination therapy with aspirin plus low-dose rivaroxaban should be considered for individuals with stable coronary and or peripheral arterial disease that are also at a low bleed risk to prevent major adverse limb and cardiovascular events. That's level evidence A.
It's very interesting, isn't it?
That was the... I think the Compass trial was the first one, and then there was like the Voyager PAD was the second one, showing that rivaroxaban, it's like the 2.5 milligrams twice a day, added to aspirin can be beneficial. Yeah, obviously the bleed risk higher, like you'd imagine, plus the cost, all that stuff. So with my new gig that I'm doing now for work, we don't have access to 340B pharmacy, so I'm having to recalibrate my thinking because before we had Xarelto for next to, at least the higher doses of it for next to nothing.
Well, some of your patients might. This depends. Some of your patients might, but
I can't just be like everyone gets Jardiance without thinking twice about it because it's $6 because it's no longer that much.
You got to think about insurances and formularies and things.
It's rough.
Not fun.
But I think that. Have you seen anybody on Xarelto 2.5 milligrams at all?
No. Well, not that I'm in the dispensing space of that much anymore.
I just mean like patient chart and stuff.
No, not that I've seen.
Because I had one guy at my last clinic that we had done that with who had already lost, I think, toes, and they were giving that a try because he had well documented PAD and uncontrolled diabetes, and so we added that on there. But Plus, we had a ton of samples and stuff that the drug rep for Xarelto was on it. So
Loaded
we had like a
job.
whole we had basically had a whole container just to dispense the 2.5 for us. So yeah, that I've done it once, but I haven't seen a lot of people go that route yet. All right, I guess let's talk about renal.
Okay.
Let me pull it up. Do you have anything specific you wanted to make sure?
No, I mean, you mentioned that they added finerenone on there, and then
Yes.
I mentioned that they kind of updated the frequency of monitoring to be a little bit more often, between like 1 and 4 times a year, depending on the severity they're recommending.
Well, and I think that's something that gets overlooked quite a bit is the albumin creatinine ratio, the urine albumin creatinine ratio. Reading that, I've seen patients who have gone 3-4 years, they have diabetes and they've never had that assessed once.
Right.
So anyone with CKD basically needs to get their albumin creatinine ratio drawn at least once a year, and then it goes up all the way to 4+ from there. But they, need to have patients with diabetes. That needs to be some kind of in the back of your mind that could become a problem, especially if they're not on an ACE or ARB or already. But yeah, the guidelines do spend some time talking kind of through the recommendations based on the risk of in keeping their kidneys as healthy as possible. And we've already talked about SGLT2s kind of at length in other episodes. But in this case, though, they do actually mention finerenone, which is Kerendia brand name. I think we've mentioned this maybe a couple times. I think we in our new drug update or whatever.
But this is an update to the guideline.
So they added it in now where it's approved for patients that have CKD that's associated with type 2 diabetes. Basically, you're trying to reduce the risk of EGFR decline, end-stage renal disease, cardiovascular death, etc. It is a selective mineral corticoid receptor blocker that's works by mediating sodium reabsorption and overactivation. And so I guess at the surface level looks kind of like spironolactone or eplerenone, but it's selectively blocking mineralocorticoid receptors, and it's one of those because it does have this potassium sparing effects, just like spironolactone does. If a patient has a serum potassium at baseline that's above 5 milliequivalents per liter, then we don't want to initiate this treatment. If it's obviously in the normal range but close to that, we want to do some monitoring. It also is contraindicated in patients that are taking a strong CYP3A4 inhibitor, as well as kind of monitoring the potassium. We need to also monitor for hyponatremia can also occur with it as well, and hypotension. So it can have some effects on blood pressure, but not. It doesn't seem to be to the same extent as like something like spironolactone would.
Right. And of course, in this section, they kind of re-mentioned the use of an ACE inhibitor or an ARB in patients with albuminuria over 30. But then they also mentioned patients who have reduced renal function, GFR less than 60, the use of an ACE or ARB. And then they say if you're using it specifically for the renal protective effects, that's not recommended for primary prevention of chronic kidney disease in patients with diabetes and a normal blood pressure with a normal albumin to creatinine ratio of less than 30. It can still be used for blood pressure, but not necessarily for preventing kidney disease progression. And of course, there's issues related to chronic kidney disease that patients are going to have to deal with along with diabetes if it's not prevented or if it gets worse. Volume overload, it's going to worsen their blood pressure with the cardiorenal syndrome and that sort of thing, electrolyte abnormalities, metabolic acidosis, anemia, bone disease, so various things that we want to try to prevent.
Yeah. So, I think that I'm curious to see, because I know some of the studies that were looking at finerenone, some of the patients were already on SGLT2 inhibitors. I'm wondering, because this kind of comes after the fact of the patient you're already potentially utilizing SGLT2 inhibitors for renal protection, along with lowering their A1C. But I'm wondering if there's going to be a hierarchy as far as these go for true kidney. Further decline of the
similar to how
function.
they did with weight management. And very high, intermediate. I wonder if they would do that with this.
Because obviously the finerenone is not going to affect the blood glucose levels. Right. But for somebody who already has more advanced CKD anyway, they're not going to really. The SGLT2 inhibitor is not going to lower the efficacy, or they're not going to have very much efficacy when it comes to A1C anyway. We just know that the kidney protection stays on board. So we saw that with the Credence trial. And I do think these guidelines did move the EGFR kind of cut point to 20.
Yeah, they moved it down. They did move it down.
With SGLT2 inhibitors. That's another update, just to throw that in there at the last second.
Right.
But for true kidney protection, I'm wondering if I still personally would go with an SGLT2 inhibitor, but I'm wondering if there's going to be any kind of comparison going forward.
Right.
But yeah, so anything else that we need to make sure that we mention? I mean, there's other little things, obviously.
There's other little things. I mean, they talk about non-alcoholic fatty liver disease and screening for that. The main takeaway from that, I think, is being aware of it and screening for it. The recommendation was made to encourage the use of the FIB4 test to screen individuals, but there's other ways to screen. People at risk would be obese patients with chronic kidney disease, older patients. But the main recommendation they have about treating or preventing is weight loss. The goal is to achieve at least 5%, but preferably a 10% weight loss. But most patients will need medications or surgery to manage their weight. In addition, you could use a GLP-1 agonist to affect that, or this is kind of another mention of pioglitazone. They mentioned that with non-alcoholic fatty liver disease as well, but they kind of had some extra verbiage in there related to that.
Yeah. So overall, I think this is I'm a big fan. Not that they care about my opinion,
no,
but I like the treatment algorithm a lot. I like
it's nice when we can go through and there's not anything that we say trash about.
It is, yeah. Again, not that our opinion matters, but
I don't feel like we trash them very often anymore.
No,
you could probably find more of that in our early episodes.
We were a little bit more rogue back then.
Yeah.
Some would argue just less informed. But no, I think I think overall, I wish that all the big patient advocate groups like American Diabetes Association would update their guidelines every year, like the COPD, the GOLD guidelines, the
I imagine it takes a lot.
Oh, I'm sure.
Right, but why are they able to do it? But hypertension is just as prevalent, if not more, than diabetes.
Yeah. And we're like, 2017, we're good. I mean, I guess that's just because there hasn't been that many.
Is it just less nuanced?
I guess.
It's true. It's less nuanced. The standards of care for diabetes is long, and hypertension, not that it's straightforward, but probably
just less updates too.
Just less updates. That's true. That's a good point. Less.
Look at us answering our own questions. Incredible.
We ask them and answer them in real time. We're like Ask Jeeves.
What that? Oh my gosh, remember him? What that really comes down to is we just need to think before we speak, and that's what really.
We could answer it in our brain before saying
instead of saying it live on.
But then there'd be long pregnant pauses.
Yeah, and so whatever.
We prefer to fill it with.
We prefer to learn right along with you guys.
Yeah.
But so. That's the major updates that we'll make sure we go over. We'll do more diabetes as time goes on, inevitably, but want to make sure we at least mentioned some of those. And like we said earlier, if you are a free CE member, then an unlimited member, not just that you've registered to get emails from them or anything, but you have an unlimited membership with them, then go to the link in the show notes, or you can go right to their website and find it under Learn. It's podcast. It's got a whole row just for them. And you click on the episode that you want credit for. And then this particular episode, it'll be listed. And you use the password ADA 2023, take the post-activity test, good to go. If you do not have an unlimited membership with freec.com, then you can't claim credit for this episode. So make sure you check them out if you have. But I've gotten a lot of text and emails and stuff about people having difficulty accessing the episodes. So it'll be in the show notes. If you are listening and you're on like Spotify or iHeartRadio or whatever, just click on the description of the episode and there's this whole long thing listed out there with a bunch of paragraphs. There's a link in there. And then if not, you just go right to freec.com and log in. But again, as always, thanks to them for working with us. The main sponsor for all of 2022 for our podcast was Pearls. So their drug information app is fantastic, and they just had a huge update come out where they added dosing and some other dosing strategies to different medications. They added a bunch of new medications on top of it that have information, drug info about that, just like a LexiComp or Micromedics or something would. Then they have all these new pharmacotherapy graphs and, treatment charts and a lot of stuff. They have a lot of really big updates that they've kind of just rolled out. So if you have not checked out Pearls, then go to pyrls.com/CoreConsultRx. You can sign up for a free account with just your email, and from there you will get access to some of the stuff on the app. You can download the actual mobile app as well on your iOS or Android device. And if you like it, which I think you definitely will, it'd be something that you can basically update to the pro version for a very reasonable price, and you get access to all of it. And the creator of it is basically adding in stuff every month, and so there's updates all the time. It's a great product. I use it myself, and so they've also been a huge supporter of the podcast, which we appreciate. And we very much enjoyed working with them throughout 2022, and wish them all the best and success going forward as well. But check them out. If you want more structured podcast episodes, then check out the Patreon that we have available, patreon.com/CoreConsultRx, and it's $3 or $4 a month. I think it's whatever it is. And, or you can pay for a year up front. It's $36 or $33 or something. And you will get access to all the slide decks, and as well as the lectures that are on there that are much more boring and traditional lecture styles. But that helps us out as well. We just added our diabetes section on there. I think the section 4 will be added in this coming week, but all the pharmacotherapy updates and all that stuff's just been re-updated on there. So check that out if you want a little bit more lecture style format. Plus there's 100 diabetes slides.
Wow.
On there altogether. So they're all
slide decks.
Not slide decks, but for the diabetes,
there's
4 mini lectures that all make up the diabetes section. It's 100 something
cool.
Slides.
That's great.
So check that out. And if you have any questions for Cole and myself, our emails will be in the show notes, and we can reach us on the social media platforms. We'll look forward to hearing from you guys. We'll see you on the next episode. Have a great one.